Thank you, sir. Good morning to the chairpersons, the respected audience. Till now, we have been focusing on venous thrombosis, that is mainly in the extremities. So I would like to focus on venous thrombosis elsewhere in laparoscopic surgery as well as in bariatric surgery. So I'd start with discussing a case which we had when we did a lap sleeve gastrectomy. So he was a 50-year-old male patient with a BMI of 71. And he was a hypertensive. He had gallstones, but he was not symptomatic, so we didn't do anything for that in the first instance. And then we performed a laparoscopic sleeve gastrectomy. The usual position we used, the modified Lloyd-Davis position. Conventional multiport was the procedure, not a single port sleeve gastrectomy. And we usually create the carboperitoneum to 15 millimeter of mercury. And that's what we did. We put a Nathanson's liver retractor. And the operative time overall was around 3 hours, just above 3 hours. So we had taken all the precautions which we do for venous thromboembolism to prevent extremity DVT. That included the low molecular weight heparins, compression stocking, which was there in the entire perioperative area. Period, and the sequential compression devices. This we put at the time of surgery before induction of the patient, and it is continued till the first post-op day when the patient is out of the ICU and is quite ambulatory. So that's what was done. So in the post-operative period, we believe in early ambulation, and in the same evening the patient was made to walk. The liquids were started after doing, confirmation on gastrographin study. And obviously the patient had stockings throughout the perioperative period, as I just said. And the patient was fine and he was discharged on postoperative day 3. He had been fine all along. And then 32 days later, near the second post-op visit, he presented again with recent onset abdominal pain, which was quite vague, but it is not localized to one quadrant. It was quite severe. We did the routine lab tests, and we found that only the TLC was raised to 14,000. The patient was kept NPO because any patient post-op after sleeve, first we try to rule out any surgical cause. So we kept the patient NPO, and USG and X-ray were all normal. So we went in for a CT scan, and the CT scan showed a thrombosis in the superior mesenteric vein, which was extending into the portal vein and the splenic vein. There was mesenteric fat stranding, but by and large the bowel was not gangrenous, or the changes of hypoperfusion was not there. So we were in a fix, so what to do? So what we did was we reviewed the literature, and the literature had a few anecdotal reports of non-extremity VTE, although it was first published in 1895 by Elliott. So the literature showed that around 10 to 15% of intestinal ischemia was because of mesenteric vein thrombosis. So this was a study which was done in London. A 37-year-old male patient underwent lap Nissen's fundoplication on post-operative day 16. Why I have highlighted this is because I will, in the end, correlate the presentation, the day of presentation. So he had a gradual onset abdominal pain, which was mainly postprandial. And then again, the lab investigations and the USG was all normal. Spiral CT was done, and you can see the thrombus in the superior mesenteric vein, which was extending into the portal vein. So he had superior mesenteric vein thrombosis, and he was advised rest, but surprisingly, he was not advised anticoagulation as such. And after 3 months, when they repeated the CT scan, they saw that it was completely recanalized. So then we move on to the next case, which was reported from the North American Journal of Medicine. A 62-year-old female patient underwent laparoscopy. I have only selected patients who have undergone laparoscopic surgery and laparoscopic upper GI surgery rather than oncosurgery or any infective cases like laparoscopy for perforated appendix, in which the incidence has been reported as slightly higher. So on day 9 of surgery, she presented with fever and urinary symptoms. So nobody, really took care of that, and she was prescribed urinary antibiotics, and she was discharged. Again, she presented day 15 after surgery, and then she had non-specific abdominal symptoms like gas, bloat, and things like that. But then everybody, blamed it on the procedure that it's fundoplication, so it's obvious. So PPIs were given. But then after 25 days, she again presented, and then now with frank peritonitis, in which a CT scan was done, and there was a gangrenous bowel, and 1 meter of jejunum had to be excised. This was a study from the USA, and I have clubbed these 3 studies together, these 3 cases together. They were all underwent lap sleeve gastrectomy, and the patients presented between 15 days to 1 month. So that is the delay of presentation. Pain was the main symptom, along with vomiting. And again, CT scan was done in all patients, and they found that obviously this is the reported case. So all patients had mesenteric vein thrombosis, and IV heparin was started, and the patients are all discharged on oral anticoagulants for 2 to 6 months. So we did the same thing. We ruled out any hypercoagulable state. We kept the patient NPO, low molecular weight heparins, and analgesics. Now the pain disappeared after 2 days. The patient was fine enough, and the liquid was started. He was resumed on a diet and discharged on day 8 on oral anticoagulants, and this time we gave the oral anticoagulants for 6 weeks. The patient is now, it's about 1 year time, and he has had expected weight loss. Now, to sum up the things, we saw that the mechanism, when we went to the literature, we saw that mechanism of causing mesenteric vein thrombosis or non-extremity DVT was first the circulation, the portal circulation decreases by 50%. Because of the compression of the pneumoperitoneum caused by the pneumoperitoneum. And so that is why they recommended that to decrease the preset pressure, the intra-abdominal pressure, to as low as possible, and to avoid prolonging the operative time much. But that is all obviously subjective. And the other factor was hypercapnia, which in itself is a causative factor for vasoconstriction. Now, all the patients presented, the main symptoms was abdominal pain followed by vomiting. So these were 2 main symptoms, and the rest of the symptoms were quite vague. It was not focusing on the mesenteric vein thrombosis. See, acute mesenteric ischemia because of arterial occlusion presents as a different way, in a different way. But venous thrombosis can present as a gradual onset pain. Investigations, again, it corroborated with our finding, and the spiral CT came out to be the best investigation, and obviously the treatment dependent on the presentation. So most of the patients would present after 15 days to 1 month, and it will be a gradual onset thing. If you pick them early, the oral anticoagulation and the low molecular weight heparins would suffice. So to conclude, again, we like to reiterate the fact that keep the intra-abdominal pressures of pneumoperitoneum as low as possible. Operative time is a subjective thing and depends on the surgery itself, but it should be minimized. You have to have a high index of suspicion because the presentations can be vague, and a CT scan becomes imperative in diagnosing these conditions. So I would like to end by what Dr. Bhatia usually says, that when in doubt, there is no doubt. So always do a CT scan, check and recheck. So thank you very much for your patient listening.
Thank you so much, Dr. Asfar. And I think that's a very important area which you have picked up. It's a non-extremity deep vein thrombosis.